Hey, Mario.
Good evening, everybody, and thank you for attending the third series of our Chronicles of Wounds Healing Investigation webinars. Please note, if you have any questions throughout this evening's presentation, use the Q&A box rather than the chat, and we'll address as many questions as possible at the end of the webinar. And as a reminder, this webinar is being recorded. My name is Kath Bogie. I am the current chair of the Education Committee of the Wound Healing Society, and pass you over to Lisa Gould, who is moderating this webinar.
Hi, I'm Lisa Gould. I'm a past president of the Wound Healing Society and have been involved with both the Education Committee and the Government Relations Committee, and we're glad that you're all here. Next up, Lee.
Hi there, I'm Dr. Lee Rogers. I am the Chief of Podiatry at the University of Texas Health Science Center in San Antonio. And thanks a lot for the invite. I look forward to having this discussion. You're muted, Larry.
Okay, good. Thanks. Thanks, Lee. My name's Larry Lavery. I'm a podiatrist and a professor in the Department of Plastic Surgery at the University of Texas Southwestern Medical Center in Dallas. So I will kick this off. How's that? You see it okay, Lee?
Yep, I see it.
All right, there you go.
Yeah, you can turn your camera off as well, Larry.
Awesome. Thanks. Need all the coaching I can get. So we're going to talk about Charcot arthropathy from bench to bedside, and I'm going to begin maybe. Yeah, so Lee and I made some last minute edits, and I think one of the things that is missed is the kind of the overview or the agenda, the objectives for the talk. So I'm going to give one side about the incidence of Charcot arthropathy. I'm going to talk a little bit about the theories of the etiology of Charcot, and then I'm going to talk a little bit about some of the basic science that explores some other etiologies. Then Lee is going to pick up and talk about treatment, non-surgical and surgical approaches for Charcot arthropathy, some of the basic or some of the standard clinical examination findings in this patient population to start. So this is from a prospective cohort study that we did in the early 2000s in San Antonio, and this is data from a disease management program. So this is 1,666 people that we followed for a little more than 2 years. And this was a managed care population from a Medicare replacement product. So, patients were, on average, like 69 years old. And this was a slice of the Medicare population that I believe Pacific Care owned at the time. So we screened people at baseline for neuropathy, vascular disease. We did arterial Dopplers, depression screening. We walked them on a force plate. and then we followed them, and we're basically responsible for their wound care, preventive services, hospital services, referral to vascular surgery. So we kind of, this was a group of people that belonged to us. And so in the 1,666 people, the incidence of Charcot arthropathy was 8.5 people per thousand, or 8.5 per 1,000 person years. And Charcot was significantly higher in non-Hispanic whites, which I think was a little bit surprising, because it seems like many things in diabetes are worse in Mexican Americans. And so Anglos were about 1.8 times more likely to develop Charcot arthropathy in this 28-month follow-up than Mexican Americans. And in South Texas, so this was a San Antonio study. So was really, there's 2% of the population at the time in San Antonio was of African descent. Most was I think probably 60-40 Mexican American, non-Hispanic white at the time. So not a common disease process. This last summer in Paris, we with Leah, had the privilege of participating in a consensus panel, and we went to the hospital and the library that where Charcot did his work. And this is a picture of Charcot's death mask, and Lee had a picture of it from a previous meeting, and has subsequently been stolen from his library. So Jean-Marie Charcot said, "How often have I seen persons not yet familiar with this arthropathy misunderstand its real nature?" And probably when he was describing this was due to tertiary syphilis and not diabetes. So this group was a magnet for what ended up being many leaders in different areas in the United States. And this is a big painting that is in the library. And so this is Charcot in the center there, and some of the other notable people. Where's Freud? Freud is supposed to. I thought Freud was in this photo too, but pick some of your favorite neurologic diseases or tests, and they were in the audience, and they would do teaching conferences in an auditorium, and then they would have small groups in essentially what was a lounge or a kitchen. So a very innovative observer of when observation and developing testing was all we had to rely on. These are some of the if you love medical history, these are some of the folks that have kind of explained, explored, or discussed this type of disease process. And one of the things we learned this summer was, at the time that Charcot was doing his work, the Germans, the British, and the French were not necessarily communicating. They weren't, exchanging literature. We were a few years away from PubMed, and so people were doing work and maybe describing the same thing at the same time, but in a different language medical journal that wasn't readily available or easy to read for the German physicians of French writing, and vice versa. So kind of we have a much smaller world now, so kind of an interesting process. So there's several theories of why neuropathic fractures occur. There's a neurotraumatic and a neurovascular theory, and kind of hybrids of those. So the neurotraumatic theory is described people that have severe sensory neuropathy. Early it was early in the discussion of this was people that had tertiary syphilis, and had enough damage to their peripheral nerves or enough sensory loss that they could injure themselves without feeling it. So they would have either a cumulative mechanical trauma, perhaps just from walking, many steps or vigorously, or sometimes a single acute episode, something as simple as a misstep off the curb or spraining your ankle that would cause this process. Most of the time, people just don't know, or their complaint is that they can't fit in their shoe, not necessarily I tripped 3 weeks ago. And the vascular theory is really a theory where there's increased blood flow to the foot. There's autonomic dysfunction or autonomic neuropathy that is paired with your peripheral sensory neuropathy that increases the blood flow, and there's a hyperemia that washes out the bone or causes osteopenia, and then resorption of the local bone from osteoclast activity, and then an easy environment then for fractures to occur. So perhaps simplistic to say, well, it's all bad neuropathy and a minor incidental trauma, but there's a bunch of other things that people have looked at to try to understand the bone morphology or pathology that may predict who is going to have neuropathic fractures. So this is kind of the standard graph of fracture, injury, inflammation, soft callus development, hard callus deformity, and remodeling. And kind of the question is, where does it go wrong that this is interrupted? And obviously, because of sensory neuropathy, it is almost always an unrecognized event. But there are what else is missing that contributes to someone that has an ankle fracture and a normal ankle fracture repair fall apart, for instance. So this is a study. So a lot of the basic science work is done in animal models and rodent models. Often they are, or some of the work I'm going to show you at least, are from animal models that are type 1 models. Often they're not treated, and so it's the question's always does this animal model help inform what happens in humans? And we like to believe that's true, but perhaps not always. So this was we get the animal model. This was a rat model that had diabetes with littermates or not littermates. And the first looks at growth factors at the level of fracture sites, and you can see on the upper far left that there is a significant difference in the expression of these growth factors compared to the diabetic rodent model. Same thing when you look at mechanical testing, torsional rigidity and shear stress in the population without diabetes is much higher. And this was a study where they administered PRP to show that it improves the torsional rigidity and maximal stress in these rodent models. So there's a number of things like the exploration of a lot of the same growth factors in wound healing, have been identified in as deficiencies in fracture healing. A lot of work has been done looking at especially the Rankel pathway to see if there's a mechanism that helps explain that. This is a streptozotocin mice model where transverse fractures were done of the tibia, and compared to littermates that were normal. So you can see the comparison of osteoclast activity, and on the right side the comparison of cartilage activity, and there's a significant difference in these comparing animals with and without diabetes over this 3 week study or so. And then the next two studies I'm going to talk about are actually from humans. So this is from a paper from Javier Lafontaine, where he took bone samples from people that didn't have diabetes, from people that had diabetic peripheral sensory neuropathy without Charcot, and patients that had diabetic peripheral neuropathy and Charcot arthropathy. And Javier was looking at this pathway and looking to see where the deficiencies might be, or where the differences might be. And what he saw was there was a significant difference in eNOS expression between all three groups, and that there was a decrease in CGRP expression in group 2 and 3 compared to group 1. And I think Javier had followed up, and we did an animal model and looked more extensively at different like some of these different factors, but not enough time to go through that in this study. And then there's this study that is looked at osteoclast activity in 16 people that had acute Charcot, 16 people that had Charcot that was quiescent and had healed, 10 people that had diabetes, and 10 people that were normal controls. And they looked at one CTP in these three models and showed that there was this significant linear relationship where this marker for bone resorption was higher in people with Charcot arthropathy. Not necessarily super surprising, I guess. And then I'm going to finish, I think, talking about the study that was done a while ago by Dave Armstrong, and I was one of the authors. Steve Walker, who's now an anesthesiologist in Dallas, was one of the authors. And I think Todd Bushman was an author. This just looks at 27 patients that had a Charcot event that were treated with total contact casting, I believe. So sorry, Lee, I robbed that from you. So next time I talk about this paper that looked at these in a similar way. People with acute Charcot, ulcers, diabetes as controls and normal controls. And this really looks at bone turnover markers in these three groups. And the yellow is the acute Charcot, and you can see it has the highest, or usually has one of the highest markers compared to normals and people without diabetes. And it is significantly higher in one CTP compared to chronic Charcot. No difference in the P1CP, and then chronic Charcot is much higher in ELK-FOS. So and then this is a study by Ed Jude using a similar approach, also looking at bone turnover markers, looking at controls in people with Charcot arthropathy, showing a similar difference. So I think we're still trying to explore, and I think the decreased cost of genomics and proteomics is going to make further exploration and understanding of the underlying pathology and perhaps identifying a target for a medical treatment, as well as that could complement surgical reconstruction, or if there's not foot deformity, may be the only intervention with offloading. So I think we're still looking in that space. So with that, I will stop and turn this over to Lee.
All right. You can hear me, Larry? All right, good. So yeah, so now I'm going to cover the clinical side of Charcot foot and bringing it to the bedside. So we heard about the science. This is us doing rounds in the morning. You can see it's pretty early. It's still dark outside, out there in the back. and we do rounds at 5:30 in the morning, and which is probably later than you did rounds, Larry, when you were down here. And oh, Larry, can you shut your camera off just so that it's full screen for everyone? There you go. Thanks. And so, how do we bring this science to the bedside? Well, first is that when we're considering the diagnosis of Charcot foot, everybody needs to have a high index of suspicion, and that's probably the most important part of the diagnosis. A red hot swollen foot is Charcot foot until proven otherwise in a patient with diabetes and neuropathy, and even in some other patients with peripheral neuropathies that are not related to diabetes, although diabetes is the leading cause in today's age. The characteristic presentation is a mostly painless foot, although some patients will complain of some discomfort or pain. It's generally unilateral. There is often gross edema. One of the things Larry said probably is the most common presentation I hear or symptom from a patient is that I can't put my foot in my shoe, and that's from the gross edema that occurs. There is a temperature differential between the extremities, and oftentimes there is an unknown mechanism or a history of minor trauma. Somebody might say, I slipped getting out of the shower, tripped on a step, didn't really think it was that significant, and then my foot just kept swelling, and now they're in this position. So generally, patients are well perfused. Oftentimes they'll have bounding pedal pulses, and then when you do see an ulcer, the ulcer is typically at the midfoot. And so, I'll have people that come in with undiagnosed Charcot foot, but have a deformity or just swelling and a midfoot ulcer only, and you can almost make the diagnosis right there. When you look at this study done by Larry and colleagues when they were down in San Antonio, looking at the neuropathic foot group versus the Charcot arthropathy group and the ulcer locations for each group, you can obviously see a much higher predilection toward the midfoot. It's very commonly misdiagnosed. I mean, it's rare that we actually see somebody early enough in the acute phase where we can make the diagnosis ourselves. In fact, these patients are often seen in the emergency department with gross edema and diagnosed as DVT. If they have a lot of rubor, then they'll get a diagnosis of cellulitis sometimes. Often thought misdiagnosed as gout, and if there are X-ray changes, it's frequently misdiagnosed as osteomyelitis. So again, having that high index of suspicion for Charcot foot and knowing what the common misdiagnoses are is really going to help you along the way. When we talk about temperature differential between the feet, we usually test the area that is either deformed or just on top of the midfoot or on the plantar foot. And if there's two different ways of doing it. One is thermometry, where you're using a contact or a non-contact infrared thermometer and checking the points individually. It is a cardinal sign of inflammation. Temperature differences are generally greater than 4 degrees to be considered significant. And you can also use temperature to monitor the response to therapy. So more advanced than that now is using thermography. And this is one of the earlier thermographic cameras that we were using. This one we got on a grant. It cost $15,000 to get this camera. But now we have things that are much less expensive that you can keep in your pocket and use. You can see here the temperature differential between the feet is 10 degrees Fahrenheit. And so now here's the one that I actually use now, which is a FLIR attachment for my iPhone. It's called the FLIR One, and they also have one for Android. And you can see here what kind of images you get, which are not only great for the diagnostic tool, but also a good patient education tool to show the patient just how inflamed their foot is, especially since they can't feel anything from the neuropathy. Here's another patient with a total midfoot dislocation. You can see the talus plantar flexed, and the navicular is on top of the talus in this lateral weight bearing image. And then look at the temperature differential between the extremities, just with that amount of inflammation that's occurring there. We have an 8-degree temperature differential. You can monitor skin temperatures during therapy to determine if the foot is cooling down or becoming more quiescent, and these temperature changes will occur over time. Imaging is useful. X-ray is probably the most useful of all the imaging, and there can be no findings sometimes, or subtle findings on X-ray. We recommend obtaining weight-bearing foot X-rays and sometimes comparisons to either the other foot, or if you have old X-rays from the same foot, to look and see if there's any subtle changes there. If you see a rocker bottom deformity, that's actually a late finding. So it was missed, and ambulation had been continued until the foot has either fractured or dislocated. The most important angles to look at are the talo-first metatarsal line and the calcaneal inclination angle. These are both done on the weight-bearing lateral films, and they can predict ulceration. So it's only if the X-ray is negative, or maybe if you're considering surgical reconstruction, but really only if the X-ray is negative do you need to move on to more advanced imaging. So here's typical X-ray findings. This is a patient that was seen in the emergency department and had a hot, swollen foot, and these are the X-rays from that visit in picture A, and you can see that the talo-first metatarsal line is unbroken. The line is continuous, and the calcaneal inclination angle is normal. And then look after 1 month of continued weight bearing and then referral to our clinic. You can see that there's dislocation at the midfoot, a lot of fractures that are occurring, and break in the talo-first metatarsal line, and a reduction of the calcaneal inclination angle. And sometimes the calcaneal inclination angle can even be negative, where it's pointed down further than the weight-bearing surface. So again, weight-bearing laterals and sometimes bilateral X-rays are always recommended. MRI is actually the most sensitive and specific for Charcot foot. Early findings are pretty clear on MRI. You can see marrow edema, trabecular fractures, some periarticular soft tissue changes, but MRI does have difficulty distinguishing Charcot foot from osteomyelitis. Therefore, if you're looking at this, you need to consider secondary signs in that, and those are that Charcot foot predominates in the midfoot. It affects multiple bones or joints, and deformity is common. So if you see multiple bones that are lining up on MRI, it's pretty unusual that would be osteomyelitis, because osteomyelitis typically is in the forefoot or rear foot and generally only affects one bone. Deformity is rare with osteomyelitis, and there's often direct extension visible on the MRI from the skin ulcer all the way into the bone. And so those are the findings that you would look for to help support your diagnosis. There are multiple classifications that exist. One that we wrote is a 2-axis classification, similar to the UT wound classification, where it's either in the forefoot, midfoot, or rear foot, an ankle. That's 1, 2, or 3. And then the stage of it is either acute Charcot without deformity, A, Charcot with deformity, B, Charcot with deformity and ulceration, C, and Charcot with osteomyelitis. And we theorize that the risk of amputation increases as the Charcot gets more proximal or more complicated. And then some of our colleagues in India, led by Vijay Viswanathan, did a validation study looking at 53 patients with Charcot and actually validated that classification that can predict amputation. So Charcot foot is a medical emergency. Why do I say that? Well, a medical emergency is a condition that where there is therapy available that can transform its natural history. And that's certainly true in Charcot foot, that we have the most important therapy, which is offloading, that can prevent this dislocation, subluxations, and ulceration and amputation. So therefore, it becomes a medical emergency. And given the short timelines that those complications can occur, it's important to act quickly. So there are medical treatments that are available. Those are offloading and immobilization. There are some pharmaceuticals that have been studied. I'll get into that briefly. And then also electrical and bone stimulation has been described as medical therapy. So most important is offloading and immobilization. Probably the best tool to use for that is a total contact cast. Total contact cast takes advantage of the shape of the leg being somewhat of a conical structure. You know, the calf is generally thicker than the ankle, and so that transfers weight because the cast almost acts like an exoskeleton, where, you know, like a crab or an insect has an exoskeleton. The hard skeletons on the outside, the soft tissues on the inside, versus, you know, mammals with an endoskeleton. But you give the patient an exoskeleton where you're creating a hard shell on the outside to take the weight and take it off of the foot and redistribute it to the calf and the leg. So it also, you can see in number 2, reduces plantar pressures. Number 3, eliminates ankle motion, so you're not getting the effect of the Achilles tendon that's causing more deforming forces. And then a couple of other things it does. Number 4, shortens the stride length, which means there's less contact time on the ground of that foot. And then it's just cumbersome to walk on, so patients take fewer steps per day when they're using a total contact cast. So offloading and immobilization, this is the same study Larry was talking about that was done down in San Antonio, but it also looked at treatment with total contact cast. 55 patients treated with serial total contact casting until quiescent. And I want to point out these numbers for you. The duration of casting was 18.6 plus or minus 10 weeks. And so that's a long time. So if you need to communicate reasonable expectations with your patients at the beginning, because if you're communicating, oh, this is similar to a fracture, maybe 6 to 8 weeks in a cast, you can see from this study that that's really not realistic, and that they need to understand that this is a limb-threatening condition. It frequently leads to limb loss, and it's going to require 18 weeks on average of casting in order to become quiescent. This is another part of the same study, but looking at breaking down the patients into those that had bilateral Charcot, those that ended up with an exostectomy or a fusion, and you can see the time in total contact cast and the time to return to their footwear. So a couple of studies on offloading using total contact cast. This one, 114 feet, 4-year follow-up, 93% were treated with the total contact cast or total non-weight bearing. 29% of those patients developed a contralateral Charcot, a recurrence, or a new ipsilateral attack. 31% developed a foot ulcer. So the point of this really is that, you know, sometimes we refer to this as conservative treatment, you know, using a total contact cast, but it's not really conservative when you look at it, because it's, you know, this is a medical emergency, something that commonly leads to amputation, needs to be treated. And so it needs to be treated aggressively, and even using the non-surgical methods, you still have a high incidence of complications, including ulceration, when you're doing this. So that should go into your calculation on whether or not surgery is indicated. So looking at the pharmacotherapies, there are some that have been described. The anti-resorptive therapies, both bisphosphonates and intranasal calcitonin. Intranasal calcitonin probably has a better described mechanism of action because it has direct action on the RANKL-OPG pathway. Also doesn't inhibit the osteoblasts, which are attempting to build the bone. But in reality, there are only very small studies, and the CDUK study, the Charcot in Diabetes United Kingdom Registry, actually found an increase in the amount of time it took to return to footwear after using bisphosphonates. So you can see there in the last bullet, use of bisphosphonates led to a longer resolution time, 12 versus 10 months. But in this, probably what is the largest registry of Charcot patients, 288, 36% recalled some type of trauma. 12% had a surgery on their index limb within the previous 6 months. So even that surgery might have been the trauma that caused the Charcot foot. We wrote that we created the joint task force, which was met in Paris in 2010. The paper was published in 2011. Larry was referring to our meeting in Paris just last year, and that was done to rewrite the statement, which hasn't been published yet. But looking at the older statement right now from 2011. Regarding non-surgical treatments, offloading and immobilization are the most important initial treatments. Available pharmacotherapies have little evidence to promote the healing of Charcot foot. Protected weight bearing is required after an active episode, and then given the high recurrence rate, close follow-up is needed. Just briefly about surgical management, it's important to address the deforming forces that are leading to the dislocations and the fractures. One of the most deforming forces is which is the pull of the Achilles tendon, sometimes referred to as equinus if the Achilles tendon is tight and there's no dorsiflexion available. And you can see here in the schematic how the Achilles tendon pulling on the posterior calcaneus causes plantar flexion of the talus and the calcaneus as a unit, which increases the pressure at the midfoot and at the forefoot, leading to these fractures and dislocations and perhaps ulceration. One of the ways to test for equinus, equinus comes from the word equine, meaning horse, because horses walk on their toes. But one of the ways to test for equinus, whether the Achilles tendon is too tight, is to simulate dorsiflexion by forcing the foot in an upward position with your hand. And you can see in that top picture, I know this says normal ankle extension. To me, this looks like a 90-degree. That would also really be defined as equinus. But some patients have what we would see in the bottom photo there, which you can't even get the foot up to 90 in reference to the leg, and that would meet the definition of equinus, and therefore one of the things to do surgically might be to lengthen or weaken the Achilles tendon, and that would help to reduce the deforming forces. So not really going into the surgical management, but just going into some of the data that's surrounding surgical management. There still is really limited evidence, although the body of evidence is growing. There was a systematic review that was published in 2012 that included about 1,150 patients that underwent Charcot foot surgery. Exostectomy is useful to relieve some of these bony pressures. Achilles tendon lengthening reduces the forefoot and midfoot pressures. And then arthrodesis is particularly useful in patients that have instability, pain, or recurrent ulcerations. Another study looking at about 1,100 feet systematic review. Now this systematic review included some of the same studies that was in the other systematic reviews. So it's not 1,100 new patients, but some of the same ones were included in this. 65% of these patients underwent internal fixation, 31% external, 4% combination. Bone fusion rate after surgery was 86%. And sometimes there's a pseudo fusion where on X-ray it may not look fused, but clinically it appears or feels as if it's a solid bone block, and that's still considered a success. 91% of these patients returned to some level of ambulation, and the amputation rate after reconstruction was only 5.5%, which is lower than the amputation rate without any treatment for Charcot foot. Although non-surgical to surgical management has not directly been studied. So to really simplify this, we put this treatment algorithm in the task force document, which is in the diabetes care article. If you just Google the Charcot foot diabetes care, it'll come up, and diabetes care is for any article that's older than 6 months is open access. So you'll be able to get this without having to be a member of the ADA or pay for it. This is the treatment algorithm. It starts with clinical suspicion of Charcot foot. We start out with x-rays. X-rays are either positive or negative. So let's say the x-rays are negative, and you move over there to the right. Then we may move to advanced imaging. And if the advanced imaging is negative, then Charcot foot is not likely. X-rays are negative, advanced imaging is negative. Charcot foot's not likely. You stop there. If the advanced imaging is positive, then we move over to offloading. Or if the X-rays are positive, we move over to offloading. Then offloading is either effective or ineffective. If it's effective, then we go straight down the middle. And after consolidation, we give prescription footwear, maybe bracing, maybe a crow, and then follow up. If the offloading is ineffective, that's when we consider surgical management. And then again, after consolidation, we do offloading and close follow up. So to end, I'll end with some of the words of Jean-Martin Charcot, who said in his 1886 paper or 1883 paper on tabetic foot. So this was the arthropathy due to syphilis. He, at the end of his paper, he wrote "Sera continue," which in French means "to be continued," because he said there's still much to be learned about this condition. And I'll tell you that probably 150 years later, that we would still say "Sera continue," because we have a lot more to be learned about the Charcot foot and its management. And I think we're ending the presentation there. We're happy to take any questions. Dr. Gould's there.
Yeah, thank you, Lee and Larry. I didn't see any questions in the Q&A yet, but I have some questions. So the first, let's lead off, because I really liked what you said about we still have much to learn. So the original or the initial slide said that the Charcot incidence is 8.5 per 1,000 diabetics, if I'm getting that right. So that, you looked at a group of diabetics. How does that compare to a diabetic foot ulcer incidence?
So during the same time period, we had, it's in the same paper. Yeah, I was re-looking at it again today. It's only 20 years old. I think during the same time period, we had like 248 people that had one ulcer. So if you count people, so let me do some fast math and I'll tell you. It's in the paper, but I don't have the paper in front of me. It's a lot lower. So let's see.
I think one of the problems is the study populations, right? So there've been some studies looking at that have reported Charcot foot incidence up to 29%, but that was in a group of patients that already had neuropathy, and then there are other studies. Probably the best study is the Danish study, because it was a survey of the entire country of Denmark, and it was around 1.5% of those with diabetes as a whole. So, and then the same thing exists with the ulcer patients, right? If you look at a northwestern population in Seattle, it's like a 2% per year ulceration risk, and if you look in San Antonio, it's what is it, Larry? Like 12% almost. So it's so I think it's really that's the issue that we have, is that we don't have a database that includes everybody.
Yeah. So the reason I'm asking that is I was noticing, sadly, that the research that's been done is about 20 years old. And is that because there's lack of funding, lack of interest, it's too rare? I mean, it seems like this, I've seen the open wounds from Charcot, and that's a great sampling. I could get a lot of tissue from that, or fluid, or anything with our new modern techniques. It would require obviously a multi-center study, but is there just not an appetite for solving this problem?
So I think, the people that I know that have tried to do larger acute Charcot studies were in the UK, where, it's easier to find, I think, investigators with, that were like-minded, and they really had a hard time recruiting subjects because it's so rare, and you have to have, you really have to have people that are going to see a patient and identify them. And, as you know, when you're in a busy clinic, unless you love research, you're just, you're just busy all day and you're
Oh, I
not.
know, that's what happens in ours. 100 patients a day, we just can't do studies. They're
Yeah.
too busy.
And you don't go, oh, Mr. Rodriguez would have been great for that study. You're just, so they had a really hard time recruiting people. And it was for some of the bisphosphonate study. And, their studies were really, really small, were small cohorts. I think they're expensive studies to fund. I think there's a lot of people that, a lot of it comes, so we're doing a study right now where we're collecting bone. So like, I think probably the biggest study where right now where there are bone samples is like less than 20. And we're collecting bone, but the money is coming from, it's one of the reasons why I do industry studies is to feed my, other habits. And so, actually it's a combination of having some really good collaborators in the core labs that do proteomics and genomics now, and the price of that technology really coming down. So you don't, you can afford to do things. So I think they're, probably in the next 6 months or a year, we should have some prospective stuff coming out. And, it's just a matter of collecting tissue. And if you have a coordinator that's calling you every day and saying, Lee, got in, saw you have 3 people are going to the OR today, need some bone or, whatever. So, it's really hard to plan a study and promise NIH or the ADA or anyone else that you're going to be able to recruit, because they're just tough.
Yeah, and IDDK hasn't even been able to do it, so we know that.
So the incidence of ulcers in that study was like 7% a year. It's one of the highest studies for ulcer incidence. In other studies range from 2% a year, and ours was the highest. But
Okay. And so you said it's also it seems like it's an Anglican disease, which might be ripe for a VA study. I think Kath is wondering if there's any resources that would allow access, say, to the VA where we might have a higher incidence. Has anybody explored that?
Well, some of the issues are the way that these are coded, so you can look at certain databases, and some databases are claims-based databases, and they're difficult to get the information out of it, unless you're doing something. But and then one of the other issues I think is that it's when you look at some of the Medicare databases, the patients are just too old. Because Charcot is now occurring in people that are typically in their 4th or 5th decade of life, and and a lot of them are working, right? So that's how they got the trauma to do this, to spark this anyway. And so they're not really in the same database,
And it's not a typical fracture pattern. So I noticed, Larry was initially presenting studies in like tibia fractures, but these ankle fractures are not the kind of ankle fractures my traumatologists take care of. Yep. So you think it really is from some small trauma and then the bones just kind of crumble?
Yeah. I think a lot of times early they're dislocations and then fractures. I think the most common site, I think Lee alluded to it, was the loose Franck joint. And a lot of times there will be early subtle changes that if you really need to look at plain film radiographs that are AP and oblique, that are weight bearing. And, there are, subtle changes that are easy to overlook. And I think the knee-jerk response in the ED, even my endocrinology friends who really understand the diabetic foot, someone comes in with unilateral edema and they're getting an ultrasound to make sure they don't have a DVT. And it's like before they get an x-ray of their foot. So they get sent home from the ED saying, you're good, you don't have a DVT. And, they their foot blows up or breaks down, I guess,
Mhm.
perhaps more.
So it's kind of neglected for a while and then it would break down. I have a couple other questions about your treatment. So we've run into the same issue with venous insufficiency where the treatment is actually compression, right? It's not taking a pill.
Right.
And all of our patients want to be able to take a pill. So how do you convince a patient that they need to be in that total contact cast for as many months as you described? Do you have a mantra? Do you have pictures? What do you use to teach those patients how important that is?
I think it's easier for Charcot than it is for a foot ulcer because people they don't come in thinking I have a soft tissue problem. I need to be in a cast, right? If you break your wrist, you go wherever to the ER or the orthopedics office. You expect to leave in a cast, and there's not even a discussion about it, right? It's like, okay, fine, and people. It's their expectations. I think that is the biggest issue on what the treatment is. I always, I try not to be the bearer of bad news or the doom and gloom person, but I always explain how high of a risk of amputation this is once this occurs, and that if we can get to this and prevent the deformity, so let's say in somebody that doesn't yet have a deformity, then we can avoid surgery, hospitalizations, the risk of amputation. And that just has to be reiterated over and over again at every visit. I do think that using thermography, which produces great photos, and when patients, they get that bit of reward when they see that their foot is cooling down in the images because they can't feel it. And one thing I didn't mention about total contact casting that's really key is that once you immobilize and offload somebody, their edema really drastically reduces pretty quickly, and so you have to be changing the cast more frequently right at the beginning because it can get too loose and they can piston and cause an ulcer inside of the cast. But that again is something that patients notice right away, that their edema has greatly reduced.
Mm-hmm. No, that's great. And that led into you use this FLIR, FLIR,
Clear, yeah.
the FLIR device. Is that universally available? Is it something that everybody that has a foot clinic should have? Can you describe it a little more?
Oh yeah, I think so. I bought it on Amazon for $300, and it's not, it's not FDA cleared, so they'll be quick to tell you that if you ever talk to the company. I spoke to they actually have a group of medical researchers that are at FLIR, and they're looking at things like finding hot spots in breasts to avoid having to need a mammogram. So if there's no hot spot, then you don't need a mammogram, so to just avoid the extra radiation there. So, but they're quick to tell you that it's not FDA cleared for this purpose as a diagnostic tool. However, people are using, you may, I don't know if you've ever used the little gun ones that you can get those on Amazon too. The infrared thermometers that have the laser pointer on them. If you're doing that, you can do that. They're cheaper. They're about a good one's about $50. But if you're using those, you have to really be careful about the standard deviation of their accuracy. And some of them may be plus or minus 2 degrees centigrade, which is fine if you're looking at whether or not to touch a hot engine part. But it's not. It falls within the sensitivity of what it is we're looking for in the foot. So the ones that cost about $50 are plus or minus 0.2 degrees centigrade, and the cheaper ones are, you can see that they really could lead you to have false sense of security. But I don't think, Larry, are you using the thermography?
Yeah. So you can get something really inexpensive for your phone that is, the back of your hands are probably can feel a difference of 4 or 5 degrees Fahrenheit. So, you touching someone probably, isn't probably a temperature device that has a couple degrees of error is going to be better than your 4 degrees of error. It's all, and I agree with Lee. It's a really nice educational piece. People think you're high tech. So someone comes in with an ulcer, you put them in a cast and you show them, it's like, look, around your ulcer was 9 degrees Fahrenheit last time, and now it's 2, and they see the picture. And I don't know, sometimes they think magical things about, oh, that's my blood flow, or that's my, whatever. It may be, when it's inflamed, it may be, but, it's why having a digital pictures, I think, in your EMR are so valuable now, because people go, oh, it's not any better. It's like, it's half the size. Let me show you the pictures. Like, oh, because so it's just one of those. It's an educational piece. It's helps you explain the disease process, helps show people they're getting better, or it's like, oh yeah, you did go to a wedding this weekend, didn't you? Because your foot is inflamed and your foot is swollen. So it's, I think it's just another, people think you're high tech. And I think, maybe you are a little bit. So I just think it gives you another tool to help, educate people. It's kind of like, I will often Doppler people and Doppler them to, the base of their toes if I can. And, they understand that is their heartbeat, or that is flow to their feet. And it's just another, and especially people that have none, it's just another part of your exam that a lot of what we do is esoteric. They don't know why we're touching them or what we're feeling. But when you can say, look, this is the pulse, this is the artery on the top of your foot. And, mine goes all the way to the toes. Yours, yours only goes to here. So it's just one of those, I think, an educational piece as well as a diagnostic tool.
There's actually a study that looked at physicians' abilities to differentiate temperatures based on water bottles they warmed to certain temperatures, and physicians couldn't tell the difference between the temperature until it was 8 degrees difference.
Wow, that's interesting to know. No, I think one of our hospitalists who works in the wound center, we trained him to do wounds. He said that our patients believe machines more than they believe us. So in the addition of that tool, I think would be really helpful. All right. Well, thank you so much. If anybody has any other questions, I'm sure that Lee and Larry would be happy to answer them. I know that they're available. And I also want to draw people's attention to the recently released diabetic foot ulcer guidelines, updated for 2023 or 4. I don't know which way you're.
3.
3. And
Published in 24.
and they're open access, thanks to the Wound Healing Society supporting that concept. So thank you guys very much for spearheading that. And I think Kath has a wrap up.
Yep. Thank you, Lee and Larry, and thank you, Lisa, for plugging the guidelines. Thank you, everybody, for attending the Chronicles of Wound Investigation series, brought to you by the Wound Healing Society Education Committee and Wound Healing U. And as a reminder, the recording will be available in your member-only account on Wound Healing U in the next few weeks. And as Lisa mentioned, we recently updated the guidelines. And we will be holding a Wound Healing Society Guidelines webinar next month on the palliative care of pressure ulcers section from the recent update to the Wound Healing Society Pressure Ulcer Guideline. And this webinar will be on March the 12th at 6 p.m. So thank you all for attending, and good night. Bye, everybody.
Thanks, everyone. Thanks.